Hello, future nurses. This is Professor Flourish. Today, we're going to be talking about some of our cardiac medications. What I've done in this lecture is I've kind of broken it down into different ways that we use these cardiac meds. So the first ones that we are going to be going over is our medications that affect our blood pressure. So like always, I like to kind of start out with just talking about some general overview of the topic. So hypertension means high blood pressure. And what that kind of includes is things of elevated force of blood against the arterial walls. Major risk factors include things like coronary, cerebral, renal, and peripheral vascular disease. Hypotension means low blood pressure. And the way we get blood pressure is by our cardiac output times our systematic vascular resistance. We've got different types of blood pressure categories here. With these ranges, you kind of want to make sure you're keeping up to date with them because these ranges can change depending on new studies and anything of that nature. So these are just some general ones here that we've got. Like a normal blood pressure is 120 to 180. Elevated would be 120 to 129 over 80. Stage 1 hypertension is 130 to 139 over 80 to 89. Stage 2 hypertension is 140 or greater, and hypertensive crisis is greater than 180, or a diastolic blood pressure greater than 120. So we can have different classifications of blood pressure. We've got our unknown causes, which are basically our essential idiopathic or primary hypertension, and that's about 90% of the cases. So with these ones, we're just not entirely sure why the patient has blood pressure. We just know that they have blood pressure. The other 10% of cases are your secondary hypertension cases, which are your known cases. And this here is basically how we control or how we have our maintenance of blood pressure within the body. So this is what's happening naturally in our body. And the reason I like to go over this is because our medications affect these different systems here. So the first system we have is our SNS. So that's our nervous system. So what happens with it is blood pressure sensors within the arterial walls. So in our arterial walls, we actually have these little sensors. There are baroreceptors, and what they happens is within the blood vessel here, they sense that there's low blood pressure. And when that's sensed, that's when the sympathetic nervous system kind of gets a signal, and then that signal causes increased heart rate, increased arterial vasoconstriction. So this baroreceptor here, what we're talking about is our alpha receptors. So in here, it's basically something is firing off saying, I don't have as much blood pressure. So now this low sense of blood pressure is firing off to let us know that we need to increase our heart rate or increase our vasoconstriction. The RAS system is controlled by our kidneys. So what happens is they sense a decrease in blood pressure by the kidneys. So the kidneys notice that they're not getting as much renal perfusion. And perfusion just basically means that blood flow to the kidneys. So there's suddenly a decrease of blood flow to the kidneys or decrease of pressure. Because remember, blood pressure has to do with all of the vessels, not just the ones going to your heart. It's also the blood vessels going to your kidneys. So all of a sudden it notices that drop. So what happens is they release renin, and then renin results in this kind of cascade of different hormones, different receptors, all kind of leading into that increased blood pressure, increased blood volume. Because it goes renin, angiotensin, then angiotensin 1, then angiotensin converting enzyme, angiotensin 2, arterial vasoconstriction and stimulation of the adrenal gland. The adrenal gland then releases aldosterone, which causes increased sodium and water reabsorption at the nephron, and then that causes increased blood volume and blood pressure. So when you look at these, when we're going through our meds, what happens is if we've got a blocker, like an ACE inhibitor blocker, we're actually blocking this process here because this is what happens naturally. And then the medications can either stimulate or block what's going on. So the overall outcome for the RAS system is that increased blood volume and increased pressure. The other one you've got is your ADH, which is your antidiuretic hormone. So what happens here is poor perfusion is sensed by the posterior pituitary gland. So it senses that there's low blood volume somewhere. So the pituitary gland releases antidiuretic hormone, and this acts at the nephron. So the nephron's located in the kidneys to increase water and reabsorption at the collecting duct, which causes increased blood volume and increased blood pressure. So these are just our basic kind of ways that we maintain blood pressure within our body. And the way the medications work will affect these different steps through here. So the target organs of hypertension, so this is why we want to control hypertension, is we've got the heart, which can cause left ventricular hypertrophy, the brain, which can cause a hemorrhagic stroke, extremities, peripheral arterial disease, retina, retinopathy, and kidney can cause damage to the glomeruli. So we're going to talk about the left ventricular hypertrophy more when we actually get into our congestive heart failure lecture. But basically what this means is hypertrophy just means like an increase of tissue. So what you have here is your left ventricle is working much harder. So it develops more muscle here. And when it develops more muscle here, it causes a more difficult time to actually pump. Because if you look at that, that's not able to actually fill up as much as this right side here. Some of your risk factors for hypertension are things like age, African American ethnicity, family, obesity, diabetes, sedentary lifestyle, nicotine use, excessive sodium in the diet, insufficient potassium or vitamin D in the diet, excessive alcohol, and stress. So our treatment. You can do lifestyle modifications such as improved diet, stress reduction, physical activity, and smoking, like stopping smoking. But for the most part, our medications are usually a lifelong therapy. So you really want to make sure that when you're educating a patient, they understand that this is not a short term, this is a very long-term therapy, and that a lot of times it can be lifelong. Because unless they modify all of these things here, then we're going to want to make sure that they're on the right regimen for these medicines. Now, with that too, if they've got primary hypertension, we don't know what's causing it, then we just really need to kind of control that blood pressure. So like I said, when you're doing your education with your patients, just make sure that they understand that this is lifelong. Some of the medications for hypertension include diuretics, antinergic drugs, vasodilators, our angiotensin converting enzyme inhibitors, our angiotensin receptor blockers, calcium channel blockers, and direct renin inhibitors. So some of the general teaching for antihypertensive care are things like you want to check their blood pressure. So you just want to make sure that your patient is looking at their blood pressure and knowing whether or not this medication is working and whether or not you need to hold the medication. You also want to make sure that you teach your patient to check with their provider before they're starting an exercise program, because what you don't want them to do is start an exercise program that they're not ready for and overexert themselves. And make sure that they keep taking the medication even if they begin to feel better. So it's really important to let them know that even if they feel better, just keep on taking that medicine, because that's what the medicine's doing. And if they stop abruptly, then they can end up having things like rebound hypertension, or they can end up causing damage to themselves. So just make sure that you're kind of, when you do your patient education, that they kind of know these main things. So the first one that we're going to be starting with is our antinergic drugs. So there's 5 subcategories. You've got antinergic neuron blockers, central and peripheral, alpha-2 receptor agonists, central, alpha-1 receptor blockers, peripheral, beta receptor blockers, peripheral, and combination alpha and beta receptor blockers, peripheral. So we kind of went over a lot of these. So the ones that we are going to focus on more in this lecture are the centrally acting alpha-2 agonists. So with the central acting alpha-2 agonists, we've got clonidine, guanfacine, and methyldopa. So the way these ones work is they act within the CNS to decrease sympathetic outflow, resulting in decreased stimulation of the adrenal receptors, both alpha and beta receptors of the heart and peripheral vascular system. So what that results in is decrease in sympathetic outflow to the myocardium, resulting in bradycardia and decreased cardiac output. So what's happening is it's going less to the actual muscle of the heart, which is causing that slow heart rate and decreased cardiac output. Because cardiac output, if we remember, is just how much blood flow we're getting from our heart. It also causes that decreased outflow to the peripheral vasculature, resulting in vasodilation, which leads to decreased blood pressure. Because if we remember, vasodilation equals decreased blood pressure. So they can be used they're primarily used for hypertension. You can administer them alone or with a diuretic or with another antihypertensive medication. They can be used for severe cancer pain. Usually those are given through an epidural. They can be management of ADHD, and they do have some investigational uses such as migraines, flushing from menopause, management of Tourette's, and management of withdrawal from alcohol, tobacco, and opioids. Some of the complications can include things like drowsiness and sedation, dry mouth, rebound hypertension. So this is what we were talking about with that lifelong journey of keeping their medications appropriately and taking them appropriately. You want to discontinue clonidine gradually over 2 to 4 days, and do not discontinue treatment without consulting provider. So you're going to see this quite a bit where we're talking about not discontinuing unless I've talked to my physician. So some of your counterindications, clonidine is a pregnancy risk category C. Methyldopa and guanfacine are pregnancy risk categories B. So methyldopa is actually okay for mama. So the reason I bring this up is because as we continue this lecture, you're going to see that a lot of these drugs are very dangerous to mama. So you just want to kind of keep note of which drugs can I give to a mother. And this is one of those drugs that's okay. And the way I personally remember is M for mom. So methyldopa is safe for our pregnant patients. It is counterindicated in clients who have had a bleeding disorder or who are on anticoagulants. So these are some of your interactions in nursing administration. So like with most of our interactions, antihypertensive medications can have an additive hypotension effect. So basically, if I give two antihypertensive medications together, then it's more likely that my patient's going to have hypotension. Concurrent use of prednisone or MAOIs and tricycline antidepressants can counteract the antihypertensive effects of clonidine. So just being aware of what antidepressants are my patient on. Because just because somebody has depression does not mean that they're not going to also have high blood pressure. Additive CNS depression can occur with concurrent use of other CNS depressants. So telling your patient to avoid alcohol. These medications are usually administered twice a day in divided doses. You want to take large dose at nighttime to decrease the occurrence of daytime sleepiness. And transdermal patches are applied every 7 days. And you want to apply that on a hairless, intact skin on either the torso or upper arm. So the next one we're going for is our angiotensin converting enzyme inhibitors. So as you can tell, all of these end in pearl. And usually ACE inhibitors work better on Caucasians. So the way I personally always remember it is Ace, like Ace Ventura. He's obviously Caucasian, and he was born in April. So that's kind of how I remember it. Pearl, Ace. So our ACE inhibitors pharmacological action. So they reduce production of angiotensin 2 by blocking the conversion of angiotensin 1 or to angiotensin 2 and increasing levels of bradykinin. This all results in vasodilation, excretion of sodium in water, retention of potassium by the kidneys, and reduction in pathological changes in the blood vessels and heart that result from the presence of angiotensin 2 and aldosterone. So I really like this picture here because it's very straightforward as to what happens in a normal function. So in a normal function, what happens is remember how I told you before that there's 3 different ways that blood pressure kind of is regulated within our body. So this is one of the ways that blood pressure is regulated. So what happens is you've got decreased circulation or decreased blood pressure. For whatever reason, I'm not having as much circulation. It could be something like I haven't drank as much, so I'm dehydrated, or it could be something like I had a trauma and I'm losing a lot of blood. Either way, I have that decreased circulation and decreased blood pressure. The kidneys sense this because remember, I want my kidneys to be nice and perfused, and I want a lot of blood going to my kidneys. So when they sense this, they secrete this hormone called renin, which stimulates the liver to create angiotensin. Angiotensin is then so then it converts to angiotensin 1. You've got this angiotensin converting enzyme here, which kind of helps speed up angiotensin going from angiotensin 1 to angiotensin 2, which stimulates peripheral arterial vasoconstriction, which then raises blood pressure. From this, angiotensin 2 stimulates the adrenal glands to release aldosterone. So your adrenal glands are the little, I call them the hats of the kidneys, but they're right here. So aldosterone increases sodium and water reabsorption into the bloodstream and causes potassium secretion into urine. The RAS-NET effect is basically increased blood volume and increased blood pressure. So if you look at all of this, this is what's happening naturally. So when I give somebody an ACE inhibitor here, what I'm doing is I'm blocking this ability to convert angiotensin 1 to angiotensin 2 so all of this down here isn't going to happen. So that's why when you're giving these medications, we get worried about our potassium. And we'll talk about this more when we get into the meds itself. But if you look at it, if I stop the stage right here, then I'm not going to have vasoconstriction, and I'm not going to have the adrenal glands releasing aldosterone, this hormone here. So I'm not going to have that sodium and water reabsorption and potassium to be leaked out. This is why our ACE inhibitors, we worry about our potassium. So if you think about it this way, it makes sense when we look at our medications. So our therapeutic uses are things like obviously our hypertensions, our heart failure, our myocardial infarction to decrease mortality and decrease the risk of heart failure and left ventricular dysfunction, diabetic and non-diabetic nephropathy. So this one here, we're going to talk about more with our lisinopril when we get down here. But this diabetic and non-diabetic nephropathy, lisinopril has renal protective effects. So it reduces glomerular filtration pressure and cardiovascular drug of choice for diabetic patients. Clients with risk for cardiovascular events, rampapril prevents MI, stroke, or death. Beta blockers and ACE inhibitors work better in Caucasians. So that's what I was talking about before. We've got our Ace Ventura here, and that's going to work better for him along with the beta blocker. But going back to my lisinopril, if I've got a patient who's got type 2 diabetes and they show some traces of protein in their urine, then it's appropriate for me to assume that the doctor is going to give lisinopril. And that's just because lisinopril, like I said, it causes that reduced glomerular filtration as well as it's that cardiovascular drug of choice for these patients. So looking at some of our complications, we can have things like orthostatic hypotension. So orthostatic hypotension is where I'll have a normal blood pressure when I'm sitting down, I stand up, and my blood pressure tanks. The other thing is cough, which is related to the blocking of ACE and that increased bradykinin. You want to notify the provider because they're probably going to discontinue this medication and maybe start them on something new. So it has to do with that blocking of that ACE. It can also cause hyperkalemia, because if we go back here and we think about it, if I'm blocking this, then my adrenal gland is not releasing my potassium into the urine. So if it's not releasing potassium into the urine, that potassium is staying inside the vasculature. So that's what's going to cause that hyperkalemia. Rash, if I'm having allergic reaction, captopril can cause altered taste. So they can have this dysgeusia, that altered taste, angioedema, that swelling of the tongue and oropharynx, so allergic reaction. And captopril can also cause neutropenia, which is decreased white blood cells. So you want to watch them for any sort of signs of infection. Some counterindications and precautions. So this is pregnancy risk D. So you want to DC as early in pregnancy as possible. History of allergies, and use cautiously with kidneys with or clients with kidney impairment. Your ACE inhibitor interactions. Diuretics can contribute to first dose hypotension. So a lot of times what your physician might do is tell them, okay, we're going to stop your diuretic 2 to 3 days prior to you taking this ACE inhibitor. Antihypertensive medications can have that additive effect. Potassium supplements and potassium sparing diuretics increase risk of hyperkalemia. So avoid salt substitutes that contain potassium. So salt substitute in NCLEX world is basically another word for potassium. So whenever you hear salt substitute, just kind of assume that they're telling you potassium. Like if you see patient education or anything like that, and the doctor says, or not the doctor, the patient says, I've been taking salt substitutes, they're trying to get you to be alert of salt substitute equals potassium. It can also increase the levels of lithium, and use of NSAIDs decrease the antihypertensive effect of ACE inhibitors. So, enalapril is the only IV medication. Most of the other ones are given orally. Blood pressure is monitored after the first dose for at least 2 hours. And you want to take captopril and Mexapril at least 1 hour before meals. And once again, we want to notify the provider if you have a cough, rash, dyskinesia, so altered taste, or indication of infection occurring. Because remember, because it's blocking that ACE inhibitor, it's causing an increase in bradykinin, which is causing that risk for a cough. So if there's a non-productive dry cough, tell the physician. Rash, allergic reaction, and captopril can cause altered taste. Also, it can cause infections because of the decrease of neutrophils. You want to report if pregnancy is suspected and rise slowly from sitting to standing. And only captopril and lisinopril are not prodrugs. So the rest are prodrugs. And the next slide, I'm going to talk a little bit about prodrugs, but a benefit for taking captopril and lisinopril are that they're better for patients with liver dysfunctions. So if you've got a patient who has who has hypertension as well as liver disease, and they're taking captopril, then something that's good for them is that it is not a prodrug. And prodrugs are basically just these drugs that are an inactive drug dose form that is converted to an active metabolite by various biochemical reactions once inside the body. So it's usually through the liver to be effective. So it's metabolized by the liver and after it's been taken in. Okay, so a patient with diabetes has a new prescription for ACE inhibitor, lisinopril. She questions this order because her physician has never told her that she has hypertension. What is the best explanation for this order? So thinking about this, right now we're talking about the patient and we're talking about ACE inhibitors. We know that ACE inhibitors are usually used for hypertension, but they can also be used for what? Yes, renal protective qualities. So let's look at our answers. We've got A, the doctor knows best, which would not be a very appropriate explanation to the patient. B, the patient is confused. I just told my patient I don't care how she feels about something. I just ignored her concerns. C, the medication has cardioprotective properties. Or D, this medication is protective on the kidneys for the sorry. This medication has a protective effect on the kidneys for patients with diabetes. Yes, because ACE inhibitors have been shown to have that protective effect on kidneys because they reduce glomerular filtration pressure, and this makes them a better choice for clients with diabetes. Okay, so the next one we're going to talk about is angiotensin II receptor blockers. So all these have are sartans. Sartan. So when you see sartan, you want to think of angiotensin II receptor blockers, also called ARBs. So sartan. These block the action of angiotensin II in the body, which causes vasodilation of the arterioles and veins, and excretion of sodium by decreasing the release of aldosterone. So it's blocking angiotensin II. So ACE inhibitors stop the formation of angiotensin II. So ACE inhibitors stopped here. So we never converted angiotensin I to angiotensin II. Angiotensin II, on the other hand, are blocking angiotensin. So yes, this is the difference between ACE inhibitors and ARBs. Angiotensin II receptors block the actions of angiotensin, and ACE inhibitors block the formation. So with our ARBs, we already have angiotensin has been developed, we're just blocking it. While with our ACE inhibitors, we're stopping even the formation of it. Okay, so our therapeutic uses, things like hypertension, heart failure, stroke prevention, delay progression of diabetic nephropathy, protective against MI, stroke, and death from cardiac causes in individuals unable to tolerate ACE inhibitors, and slow the development of diabetic retinopathy. Some complications include things like angioedema, fetal injury, hypotension, dizziness, and lightheadedness. So you see how I was talking about the pregnancy risk D. So a lot of these antihypertensive medications are not safe for somebody who's pregnant. So you want to DC as early in pregnancy as possible. They're counterindicated in clients who have bilateral renal stenosis or only have one kidney. And you want to use cautiously with clients who have had reactions to ACE inhibitors. If you think about the receptors that are being affected here, they're at a very close space. So if they reacted poorly to an ACE inhibitor, then more than likely they're also going to act poorly to a angiotensin II blocker. Some of your interactions, antihypertensive medications can have an additive effect when used with ARBs, and they can increase the risk for lithium toxicity. So some of your nursing administrations include things like administer medication by oral route, and they can be taken with or without food. So the next ones we're going to be talking about is our calcium channel blockers. And if we remember, calcium channel blockers work better with our African Americans. So they work better with our African American patients. Now, most of these, except for Rampamil and Diazepam, all end in pine. So your calcium channel blockers, if you're looking for them, you're looking for that PINE, pine. Nifepine, amlodipine, plenopine. Well, it's pine, not pine, sorry. So nifedipine, it acts by blocking. I just put like nifedipine so that way it's a little bit like easier to remember, because most of your pines kind of do the same thing. So the way this one works is blocking of calcium channels in the blood vessels, which leads to vasodilation of the vascular smooth muscles and arterioles and arteries and arterioles of the heart. It acts primarily on the arterioles, and veins are not significantly affected. So with nifedipine, it's mostly hitting the arteries or arterioles. Rampamil and Diazepam block calcium channel blockers and cause vasodilations of the peripheral arterioles and arteries and arterioles of the heart. Blocking of calcium channel in the myocardium, SA node, and AV node causes decreased force of contraction, which causes decreased heart rate, which causes slowing of the heart or slowing of the rate of conduction to the AV node. So this is why we can use them as a rhythm medication. They act on the arterioles and the heart at a therapeutic dose, and veins are not significantly affected. So I've got this little chart for you guys that makes it a little bit easier when you're looking at these. All of them can be used for hypertension. Now, some of these can be used for other things, like angina, so that's chest pain. Chest pain, you can see it with nifedipine, amlodipine, niacarbine, and Rampamil, and diltiazem. So all of these can be used for chest pain. And your cardiac dysrhythmic drugs are your Rampamil, can be used for that. So once again, calcium channel blockers with diazepam diuretics work better in African Americans. So some of the complications can be things like reflective tachycardia, acute toxicity, orthostatic hypotension, and peripheral edema with our nifedipine. With our Rampamil and diltiazem, it can also be orthostatic hypotension and peripheral edema. And it can also cause constipation, which that's primarily with your Rampamil. So with this one, you're going to instruct the client to drink more fluids and eat more fiber diet. And if we think about fiber diet, you want to think about things that are high in fiber. That can be things like your bran muffin. That can be things like the skin of an apple, just things that are going to help with their constipation, because we always want to do the least invasive thing we can. So we don't want to jump to giving them medications. We want to first try to see if, okay, I'm going to give you more water and see if that helps. Some of the other complications are suppression of the cardiac function. So they can have things like bradycardia or heart failure. Dysrhythmias, acute toxicity can cause things like hypotension, bradycardia, AV block, and ventricular tachydysrhythmias. Some of your counterindication is it's a pregnancy risk C. Nifedipine is counterindicated in clients who are in cardiogenic shock, and you want to use cautiously in older adults and clients who have kidney or liver disorders and mild to moderate heart failure or GERD. So Symptotide, ranitide, and grapefruit juice can all lead to toxicity in our nifedipine patients. Rampamil and diltiazem. Rampamil can increase digoxin levels increasing risk of digoxin toxicity. So digoxin can cause additive effect and intensity of AV conduction suppression. So just making sure you're looking at, are they taking digoxin at the same time as verapamil? Concurrent use of beta blockers can lead to heart failure, AV block, and bradycardia, and consuming grapefruit juice can lead to toxicity. So avoiding grapefruit for them. Okay. You want to administer these infusions slowly over a period of 2 to 3 minutes. Teach clients to monitor blood pressure and heart rate, and teach clients not to chew or crush sustained release tablets, and change positions slowly. Okay, if you guys want to take a small break, we will come back and I will finish the other ones. Okay, so we are now going to be talking about our antidysrhythmic drugs. Before we begin, I've got this video here that you can watch. If you download my PowerPoint, you can download the video. I found out that recording, it doesn't really go through, but this just shows the cardiac conduction system and ECGs, because it helps you a little bit when you're going over this to kind of know what a normal rhythm is. And this right here is a normal rhythm. We've got our lovely P wave here, our QRS, our ST and T wave. So what you're looking for is basically, it's the conduction. So it's SA node going to AV node, going down. That's allowing us to actually have the pump. So yes, this here is just kind of showing again, this is where we have arterial depolarization, ventricular depolarization, ventricular repolarization. So that's how the normals work. And this is the medications affecting cardiac rhythm. So they act by altering cardiac electrophysiological function in order to treat or prevent dysrhythmias. This can include prolonging the AV node. So when it comes, you can't really see it here, but when you have your AV node here, it's prolonging that action. So it's slowing down the electrical impulse, increasing or reducing conduction speed, altering etopic pacemakers and SA node, reducing myocardial excitability, lengthening effective refractory period, and stimulating the autonomic nervous system. So the 4 main classification groups of antidysrhythmics are sodium channel blockers, beta adrenergic blockers, potassium channel blockers, and calcium channel blockers. And something to be cautious about is, first of all, toxicity is a major concern for antidysrhythmic medications. And one of the potential adverse effects of any antidysrhythmic drug is dysrhythmias. I'm going to repeat that one more time because it's something that I really want you to understand, is potential adverse effect of any antidysrhythmic drug is dysrhythmias. So you can give a medication that's going to cause a dysrhythmia. So you just want to be aware that whenever a patient is starting an antidysrhythmic therapy, the nurse needs to know that a potential complication can be a dysrhythmia. Because think about it, we're messing with our SA node, we're messing with our AV node, we're messing with the excitability, the conduction, we're messing with the electricity of the heart. So by doing that, I can accidentally throw somebody from a normal rhythm into a dysrhythmia. So the first one we're talking about is our class 1 medications, which is our sodium blockers. So sodium blockers slow cardiac conduction velocity, and it's divided into 3 groups, A, B, and C. So these are just the different ones that are in the different groups. We've got class A, class B, and class C. Class A slows the impulse conduction in the arterial ventricles and his system, delay depolarization, and they're used for SVT, ventricular tachycardia, A flutter, and A fibrillation. Our class B, or class 1B, in the arterial ventricles and his system, it causes decreased electrical conduction, decreased automacy, increased rate of repolarization, and it's used for short-term use of ventricular dysrhythmias. As you can see, there's going to be a common theme. Most of these medications are used for ventricular issues. Our class C, decreased conduction velocity in the arterial ventricles in his system, delayed ventricular repolarization, and it's used for SVTs. So some of the medications I want to focus on a little bit more from our class 1 is class 1B lidocaine and phenytonin. So both of these are blocking the sodium channels. They accelerate repolarization, cause increased or decreased APD. And lidocaine is used for ventricular dysrhythmias only. So that's what lidocaine is used for when it comes to this. Now, lidocaine is used for other lidocaine has multiple uses, but if you're using it for rhythms, then it's only used for ventricular dysrhythmias. Phenytonin is used for arterial and ventricular tachydysrhythmias caused by digital's toxicity or long QT syndrome. So the reason I bring up phenytonin is because I kind of want you to remember this one because you'll see it multiple times when you're just looking at counterindications. But yes, it's used for arterial and ventricular tachydysrhythmias caused by our digitals and that long QT syndrome. So the reason I bring up lidocaine is because it's one of those medications where, for me personally, I just was always very paranoid whenever I gave it because of its side effects. So with it, its side effects can be things like drowsiness, altered mental status, paresthesia, seizures and convulsions, and respiratory arrest. So with it, what will happen is the way it explains it on the side effect sheet is your patient will start feeling numbness, and then it leads to altered mental status, and then it ends in convulsions. So me, I was always paranoid. Every single time I walked into the room, I was like, how are your toes feeling? How's your fingers feeling? Do you feel like you're going numb? Anything of that nature. Because the reason we used lidocaine in that sense was for something other than the ventricular reason. So I was just always paranoid that they were going to have a seizure. So I guess that's kind of why I'm just like very much like, yes, know that a possible side effect is seizures. So your beta blockers, your class 2 medications, beta blocker energetic blockers prevent sympathetic nervous system stimulation of the heart. Some medications can be things like propranolol, asmolol, acebutolol. So since they're blocking it, it's going to cause a decreased heart rate, decreased atomicity through the SA node, decreased velocity of conduction through the AV node, decreased myocardial contractility, and decreased arterial ectopic stimulation. Some of the uses are things like AFib, A-flutter, SVT, hypertension, angina, PVCs, and severe recurrent ventricular tachycardia. Then we've got our class 3 medications, which is our potassium channel blockers. And the way these ones work is they prolong the action of potential and refractory period of the cardiac cycle. I've got listed here some of your medications. The one that I'm going to go over the most right now is your amiodarone. Right. So expected pharmacological action is that it delays repolarization, prolongs action potential, reduces atomicity in the SA node, reduced contractility and conduction in the AV node, ventriculars in his system, and dilates coronary blood vessels. Therapeutic use, converting AFib, recurrent ventricular fibrillation, recurrent ventricular tachycardia. So an amiodarone Some of its uses are superior ventricular dysrhythmias. So if a patient's had a heart attack and they're experiencing superior ventricular dysrhythmias, one of the medications that they'll use is amiodarone. We used amiodarone a lot in my post open heart patients, because right after somebody has open heart surgery, because the way open heart surgery works is it's usually done with a graft where they harvest veins from their leg and they put it in their heart to basically reroute how the blood works in their heart. So usually right after that, not usually, but a lot of times, right after they would have the open heart surgery, they would go from normal sinus rhythm to a dysrhythmia. And that's because if you think about it, the conduction, it's not used to having those electrical impulses going through a heart that's no longer blocked. So it just takes the heart a little bit of time for it to repump, re-get together, do what it's supposed to do. So what would happen is they would end up having dysrhythmia. So what the doctor would prescribe is amiodarone, because it's a pretty safe drug to give them. And the amiodarone was designed to hopefully keep them from, to put them back into a normal rhythm, so they're no longer in something like AFib or superior ventricular dysrhythmias, anything of that nature. So that's why amiodarone is very useful in that sense. Now with it, you just have to watch for things like bradycardia, visual disturbances, inflamed veins with IV administration, hypotension, bradycardia, and AV block. I want to pause it to show you this. With amiodarone, what you'll usually have is a filter, because amiodarone tends to, let me see if I can see amiodarone IV. Amiodarone tends to have quite a bit of bubbles in it. So what you'll do is when you give the medication, you give it with a filter. So usually, sometimes it'll come with the medication, sometimes it won't come with the medication. And sometimes like some places they'll have it located in the Omnicell, sometimes they'll have it located in the where pharmacy will send it to you. The point in my saying that is that this medication has a lot of bubbles, so you just have to be careful with it, and you don't just give the medication straight. You have to give it through a filter, so it filters out all the bubbles before it gets to the patient. With it can cause phlebitis, which is that inflammation of the veins. So you just want to make sure that you're watching their IV site. We talked about some of our calcium channel blockers, but our class 4, our calcium channel blockers prolongs cardiac conduction, decreases depolarization, and decreases oxygen demand of the heart. So some of the medications that are calcium channel blockers are our verapamil and diazepam. We're going to talk about adenosine, and then when we get to our heart failure, we'll talk about digoxin. So adenosine is interesting. It slows the conduction to the AV node, and it's used to convert PSVT to sinus rhythm. So this is another one of our ventricular rhythm drugs. It's got a very short half-life. So the half-life is usually less than 10 seconds, and it's only administered as fast IV push. So this one's one of the ones that you push very quickly. And it may cause asystole for a few seconds. So asystole is basically where you've got that lovely little rhythm of heart beating, and then it stops, and then it starts beating again. And the idea behind this is that we want to kind of jumpstart the heart. Like, let me see if I can show you KG. Okay. And I will say it's like super scary when it happens. And this is why a provider has to be there with you when you give this medication. Because as you can see here, they've got SVT here, SVT here. They give adenosine, it stops, and then their rhythm starts again. So that's like the big thing with it, is it's going to stop, and then restart. And you just want to make sure that you have a provider with you when you give this medication. Adverse effects are minimal. And this is just one of those ones you push quickly. And so a patient has received an IV dose of adenosine, and almost immediately the heart monitor shows asystoles. What should the nurse do next? Continue to monitor the patient. And that's because with this medication, it's designed to do that. It's what we're expecting. And it should only last for a few seconds, but you just want to monitor your patient. That's why we have a provider there with us. If you want to take a break, we will come back and do medications for chest pain. Okay, so our medications for chest pain. Before we begin, I just want to talk to you about acute coronary syndrome, just so we can kind of understand what I mean by angina. So acute coronary syndrome is a term used for 3 ischemic disorders of the heart that occur suddenly and require immediate treatment. So ischemia is decrease of oxygen, while infarction is tissue death. So when we talk about ischemic disorders, we're talking about decreased perfusion, decreased oxygen. So you've got unstable angina, which is cardiac chest pain that is new or occurring for the first time. Then you've got STEMI and non-STEMI. So a STEMI is ST segment elevation, myocardial infarction, which is a medical emergency. Non-STEMI is non-ST segment elevation, myocardial infarction. And what we're talking about here is, sorry, let me go all the way back to my EKG. ST elevation is this portion here. So you see this here, this would be if it was elevated completely. Such as on, well, picture I've got on the side here. See where they've got ST elevation here? That's what we're looking for. And ST elevation means that it's a STEMI. They're having a myocardial infarction, which means that tissue death. And that means we have to do something immediately. Non-STEMI means that they are having a myocardial infarction. It's just not showing on their rhythm. So causes of your myocardial ischemia. Ischemia means that decrease of oxygen or decreased blood flow. You can have a thrombus, which is a blood clot, obstruction of blood flow to the heart muscle. If the coronary artery diameter is blocked by 50 to 70%, an inadequate amount of blood flow flows past the blockage, which causes ischemia. So that's where we've got this blood clot and he's blocking this artery. Arteriosclerotic plaque develops in the coronary artery. Most common cause, as the plaque ages, it calcifies and becomes fragile. A piece of calcified plaque often breaks off and travels downstream. So that's where you get the embolism, and lodges in a small diameter arteriole. After lodging in the arteriole, the piece of plaque obstructs blood flow into the distal myocardial tissue. Because what happens here, what we're getting concerned about is any sort of blood flow blocking here. That's why if you have a myocardial infarction, or if you've got some sort of blood clot that's blocking up here, then it's going to cause more damage, opposed to if I had one that was down here. Coronary artery vasospasms are less common. The vascular spasm obstructs blood flow through the coronary artery, ischemia in the surrounding myocardial tissues. When the artery relaxes, circulation is returned to the myocardium. So basically what happens here is the artery just basically quivers. And when it quivers, that's what's causing the decreased blood flow because it's not flowing appropriately. You can have an acute MI, so that's the acute coronary syndrome. So occurs when the heart tissue endures prolonged ischemia without recovery. Myocardial cells suffer irreversible damage because of hypoxia, cell death, ischemic necrosis. Can be classified as STEMI or non-STEMI. The difference is whether or not you're seeing it on the EKG. The extent of damage caused by the myocardial infarction is influenced by 3 factors: location or level of occlusion in the coronary artery, length of time that the coronary artery has been occluded, and heart's availability of collateral circulation. So this is what I was talking about before, is depending on the location of where the block happens is how much damage you're going to have. Because if I have a block way up here, then it's going to cause all of this area to be damaged. If I have a block down here, then this area is just going to be damaged, but the whole heart's not going to be damaged. So angina, our chest pain. So our angina pectoris, squeezing pain in the chest that occurs when there's a lack of blood flow to the myocardium, termed myocardial ischemia. So this can be described as stable or unstable. The difference between stable and unstable chest pain is whether or not it's new or not. If it's a new or changing chest pain, then it's unstable. If it's one they've had before, then it's considered stable. So like I said, unstable is that new or changing. Stable is that chronic chest pain. So it's predictable. The patient has a prescription of medication for episodes and medicates for treatment. So these are our classic cardiac chest pain. Patients report retrosternal chest pain discomfort and uses pain or terms such as pressure, choking, squeezing, or heaviness. A crushing sensation felt on the left side of the chest, radiating to the left shoulder down the left arm, can radiate to the jaw, back, neck, right arm, or epigastric region. Clenching fist over chest, diaphoresis, pale, dyspneic. And pay close attention to patients reporting these signs. So you just want to make sure that if they start saying that they're having these chest pain, that you want to know if it's new or one they've had before. Well, these are just some of our diagnostic tools for it. You can have myocardial perfusion scan, which is your stress test. It shows myocardial perfusion during exercise and rest, often done when patients are experiencing angina. The patient exercises to maximum level on a treadmill or stationary bike while radioactive substance called dilithium is injected into the bloodstream. Dilithium highlights the coronary artery blood flow and deficits of the blood flow to the heart while it is stressed by the exercise. It can be done either using a treadmill or it can be done by using medications that are going to raise our heart rate. So EKGs alone cannot diagnose an MI. If an MI is suspected based on the EKG, clinicians will usually order serial cardiac CPKs and troponins every 8 to 12 hours for 1 to 2 days to follow the progression of an MI. The rise and fall of these biomarkers provides an indication of the extent of myocardial cell death, and troponin is used to confirm a diagnosis of an MI. So these are our drugs for angina. You've got our nitrates, beta blockers, and calcium channel blockers. So I'm going to focus on our nitrates because we talked about these other two previously. So our nitrates are available in all kinds of forms. You've got sublingual, chewable, oral, IV, transdermal, ointments, and translingual. All the ones that have a little star next to it bypass the liver in the first pass effect. Nitroglycerin can be both rapid and long-acting. Isosorpin dihydrate can be both rapid and long-acting. Isosorpid monotrate is primarily long-acting. So what these do is cause vasodilation because of relaxation of the muscle tissues or of the smooth muscle. Potent dilating effect on the coronary arteries, which results in oxygen to the ischemic myocardial tissue. So if you think about this, it makes sense why we would use it for chest pain, is that my concern is that I'm having ischemia, so I'm trying to open up the vessels as much as they can in order to get more oxygen there. It is used for the prevention and treatment of angina. You can use to treat stable, unstable, and vasospastic angina. You've got rapid forms, which are used to treat acute angina attacks. Those are your sublingual and IV infusions, and then long-acting forms, which are used to prevent anginal episodes. Now, something that you kind of want to know about your nitroglycerin drugs is that one of the counterindications for it is erectile dysfunction medications. And that's just because they also cause that vasodilation. Like the first time they even created Viagra or sildenafil was because they're trying to figure out heart medications. They're trying to find something to help cure chest pain. And instead they found out that it could cause an erection. So that's why they're like, oh, well, we can just use it for this. So if somebody comes to the hospital and they have chest pain, you want to ask them, have they taken any Viagra or anything that's going to cause anything that's used for their erectile dysfunction. So the nurse is obtaining a medication history on a patient presenting with chest pain. What drug classification would necessitate the nurse informing the provider before beginning the prescribed nitroglycerin? Yes, our erectile dysfunction drugs, B. So your counterindication are known drug allergies, severe anemia, closed angle glaucoma, hypotension, because if it's causing vasodilation, it's also going to cause blood pressure decrease. Severe head injury and use of erectile dysfunction drugs, sildenafil, tadalafil, and radafil. So if you're ever wondering which ones are your erectile dysfunction drugs, they all end in a fil. Poor Phil has erectile dysfunction, so now he has to take sildenafil. Oh, I thought it was funny. So some of the other ones are going to be headaches. So they're going to complain about a headache with this, and what you just have to explain to them is that's kind of part of the process. It'll usually diminish in intensity and frequency with continued use. They can also get reflection tachycardia, postural hypotension, skin irritation with topical application, and tolerance may develop. Tolerance occurs in patients taking nitrates around the clock with long-acting forms. Prevention by allowing a regular nitrate-free period to allow enzyme pathways to replenish. So usually what you want to do is remove the patch at bedtime and then reapply a new patch in the morning. A patient with a known history of angina was walking his dog and developed chest pain. The patient immediately stops walking and sits down. He continues to experience chest pain when sitting down. When should he call 911? So what he'll do is, if the first sublingual tablet does not relieve the pain after 5 minutes. So he'll take his pill first, and then he'll call 911 if it hasn't fixed it in 5 minutes. Isosorphate dihydrate is an oral nitrate available in rapid acting sublingual tablets, immediate release tablets, and long acting oral dose forms. It provides more consistent, steady therapeutic response. Nitroglycerin, prototypical nitrate. It's the most important drug used in symptomatic treatment of ischemic heart conditions. Routes PO, sublingual, meteor dose aerosol that is sprayed under the tongue, IV, and topical. So you can very much use it for anything. It's got a large first pass effect with oral forms. It's used for sympathetic treatment of ischemic heart conditions. IV form can be used for blood pressure control in perioperative hypertension, treatment of heart failure, ischemic pain, pulmonary edema associated with acute MI, and hypertensive emergencies. So these little general rules here are pretty important for you guys to know. I'll just be honest, these rules, when you're studying, make sure that you know all the rules that come with nitro, because NCLEX likes to ask you about these. They're good to know when you're out in clinical, and it's good to know just in a general basis, everything you're supposed to do with nitro, because it doesn't matter where you're at, anywhere you're at, somebody can have chest pain. So nitroglycerin part 1, you want to instruct patients in proper technique and guidelines for taking sublingual nitroglycerin for chest pain. Instruct clients never to chew or swallow the sublingual form. Instruct patients that a burning sensation felt with sublingual forms indicates that the drug is still potent. Instruct clients to keep a fresh supply of sublingual medications on hand. Potency is lost in about 3 months after the bottle has been opened. To preserve potency, medication should be stored in an airtight, dark glass bottle with metal cap and no cotton filler. Instruct patients in the proper application of nitrate topical ointments and transdermal forms, including site rotation and removal of old medications. So make sure that they're removing their medication, for example, at bedtime, and then reapplying a new one in the morning. You don't want them to put one on, go to bed, and put a second one on. To reduce tolerance, the patient may be instructed to remove topical forms at bedtime and apply new doses in the morning, allowing for nitrate-free period. Remember, we want to replenish the body, so you don't want them to just constantly have this on. Instruct patients to take as needed nitrates at first sign of anginal pain. Monitor vital signs frequently during acute exacerbations of angina and during IV administration. If experiencing chest pain, the patient taking sublingual nitroglycerin should lie down to prevent or decrease dizziness and fainting. So just making sure that they know once the chest pain starts, sit down immediately, then take the first nitrile sublingual tab. If anginal pain occurs, so this is the one, make sure to pay a lot of attention to. Stop activity, sit or lie down, take the sublingual tablet. If there is no relief in 5 minutes, call 911 or emergency services immediately and take the second sublingual tablet. If there is no relief in 5 minutes, take a third and do not drive to the hospital. IV forms of nitroglycerin must be given with special non-PVC tubing and bags. Discard parenteral solution that is blue, green, or red color, and follow specific manufacturer instructions for IV administration. Okay, if you want to take a quick break and then come back, we'll do medications for heart failure. All right, so our medications for heart failure. What I have here is 2 different videos. This first one is about the blood flow to the heart in 2 minutes. It's very helpful in my opinion. It just kind of shows where everything's going. This next video just talks about what heart failure is. It's about 8 minutes, but it's very helpful. So heart failure is the inability of the heart to maintain adequate cardiac output to meet the metabolic demands of the body due to impaired pumping ability. You've got weakened ventricular muscle, unable to sufficiently pump blood into the arterial circulation to meet the needs of tissues. It's a very common cause of hospitalization, and clients are now living longer with heart failure due to improved treatment. Symptoms depend on the cardiac area affected. Common symptoms are things like dyspnea, fatigue, fluid retention, and or pulmonary edema. Left-sided heart failure has pulmonary edema, coughing, shortness of breath, and dyspnea. Right-sided heart failure has systematic venous congestion, pedal edema, jugular venous distension, ascites, and hepatic congestion. And if we think about it, it makes sense because the left side of the heart is supposed to be pushing things out. And if it's not pushing things out, it's backflowing into the lungs. So you're having all those lung problems. So left, I always think of left for lungs. Right-sided is we're not pulling it back, so everything's staying in the tissues. That's where you're getting that edema. Drug therapy, we've got all kinds of different drug therapy that we use on here, and we're going to kind of go over some of these. So drug of choice for early treatment of heart failure, focus on reducing effects of the renin, angiotensin aldosterone system in the systematic nervous system, ACE inhibitors, ARBs, and certain beta blockers. Some of the other early treatment of it are things like loop diuretics, aldosterone inhibitors, And only after all these drugs have been used do we start using digoxin. Dobutamine is a positive inotropic drug. Hydralazine and isosorpin dihydrate became the first drug approved for specific ethnic groups. Let me put this on pause. Okay. So hydralazine and isosorpin dihydrate were approved specifically for the use in African American populations. We've got our ACE inhibitors responsible for converting angiotensin 1 to angiotensin 2 because they inhibit that ACE, prevent sodium and water reabsorption, diuresis results, so decreased preload. And examples are things like our lisinoprils, captopril, all those ones that we went over. And just kind of a refresher, our lisinopril uses for hypertension, heart failure, and acute MI. It can cause hyperkalemia because remember, if we block that, we're not losing potassium, so we're still holding on to potassium. Common adverse effects: dry cough, hyperkalemia, decreased renal function. Angiotensin 2 receptor blockers, potent vasodilators, decrease systematic vascular resistance, can be used alone or in combinations. And it shares, valsartan shares many of the same adverse effects as lisinopril, and ARBs are not as likely to cause cough associated with ACE inhibitors. And they're also not as likely to cause hyperkalemia. So our angiotensin receptor niclosin inhibitors, these are a newer class of drugs. So it's kind of like a combo drug. It blocks the degradation of vasoactive peptides by inhibiting them. And common adverse effects are hypotension, hyperkalemia, and increased creatinine. Our beta blockers, so carvedilol is one of the beta blockers that we use quite a bit for this heart failure. Cardioprotective quality of beta blockers. They prevent cataline-mediated actions on the heart by reducing or blocking sympathetic nervous system stimulation. And intended effects: reduce heart rate, delete AV node conduction, reduce myocardial contractility, and decrease myocardial atomicity. Aldosterone antagonists are useful in severe stages of heart failure. So usually you won't see these until it's like pretty severe. They cause the activation of renal angiotensin aldosterone system, which causes increased levels of aldosterone, which causes retention of sodium and water, leading to edema that worsens heart failure. Spironolactone, we're going to talk about more when we get into our diuretics, but these are potassium-sparing diuretics and shown to reduce symptoms of heart failure. Epinephrine is selective aldosterone blocker, which blocks aldosterone at its receptors in the kidneys, heart, blood vessels, and brain. Hydralazine was the first drug approved for specific ethnic groups. Dobutamine is a beta-1 selective vasoactive and structurally similar to dopamine. Ivabradine is SA node modulator. It's used in stable and systematic heart failure with ejection fraction equal to or less than 35. And with them, you want to avoid grapefruit juice. B-type nitrouric peptides. So our nesitride has vasodilating effects on both the arterioles and veins. And then what it's going to cause is diuresis along with nitriuresis. So you're going to have urinary sodium loss and fluid loss and vasodilation. And this medication is used in intensive care setting as final efforts to treat severe life-threatening heart failure, often in combination with other cardiostimulatory medications. So this one you usually only see in the ICU. So a client is best candidate to receive nesitride therapy. A patient with AFib who has not responded to other drugs, a patient getting initial treatment for heart failure, a patient with reduced cardiac output, or a patient with acutely decompensated heart failure who has dyspnea at rest. So D, because that is our sickest patient. Our phosphatase inhibitors work by inhibiting the enzyme phosphatase, result in intracellular increase in CCAMP, positive inotropic vasodilators, increase in calcium and myocardial muscle contraction. And they are isodilators, so inotropics and dilators. These are used for short-term use of heart failure of patients in the intensive care unit. And then the ANA and ACC advise against long-term infusions. Our Millerone, only available phosphatase inhibitor. Millerone is available only in injection forms. Adverse effect are things like cardiac dysrhythmias, headaches, hypokalemia, tremors, thrombocytopenia, and elevated enzyme levels. Interacts with diuretics and digoxin. Okay, so I went over those ones pretty quickly because those are a lot of our intensive care drugs. So you'll hopefully, if you decide to go to intensive care, you might see them a little bit more. These ones here are cardiac glycosides, are ones I want you to focus on a little bit more. It's one of the largest groups of cardiac drugs. They're no longer used as first-line treatment. Not been shown to reduce mortality in heart failure patients. And they were originally obtained from digital plants, foxglove, and digoxin is a prototype used in heart failure and to control ventricular response in AFib. So mechanism of action, they increase myocardial contractility and change in electrical conduction properties of the heart. So with digoxin, that's one of the first ones I'm going to be talking about. It's got positive inotrope, so increased force of myocardial contraction, and negative chronotropic effect, so decreased heart rate. As a second-line medication treatment for heart failures, for females, used only if the client has not responded to first-line medications. Just because of the increased risk of harm, dysrhythmias, and can reduce manifestations, but not prolong life. So digoxin is one of those drugs that NCLEX loves to ask us about. So it's one of those ones that you really do want to get a good understanding of it. It's got a very narrow therapeutic window, and drug levels must be monitored. And the drug levels are 0.5 to 2. Low potassium levels increase its toxicity, and electrical levels must be monitored. Sorry, electrolyte levels. So just make sure that you know your level for digoxin. So for example, if somebody was preparing to give a digitals that is 3 ng per mLs, you would want to hold it and notify the physician. These ones also have a lot of adverse effects, and their adverse effects are things that you really want to know. So it can cause things like headaches, weakness, confusion, convulsions, but with it, the thing is with the eyes. So it causes colored vision. So seeing green, yellow, purple, halo vision, and flickering lights. If your patient is on digoxin and they say that they're starting to see green, yellow, or halos, then you want to assess them for symptoms of digoxin toxicity. And with anything, I always tell you, make sure that you know what your antidote is. So the antidote for digoxin is digoxin immune fab. So make sure you know that. The other thing is you want to watch your patients for hyperkalemia, life-threatening cardiac dysrhythmias, and life-threatening digoxin overdose. A patient is receiving digoxin 0.25 milligrams per day as part of treatment for heart failure. The nurses assesses the patient before medication its administration. Which finding is of most concern? And it's going to be that potassium level of 2.9. So these are some of your predispositions to digoxin toxicity. Hypokalemia, so if they've got low potassium, use of cardiac pacemaker, advanced age, everything of that nature. You want to assess the history, drug allergies, and counterindications, assess blood pressure, and you want to listen to the apical pulse for 1 minute, heart sounds and breath sounds. Assess clinical parameters, weight, input, output measures, electrical cardiogram, serum labs, potassium, sodium, magnesium, calcium, renal, and liver function studies. And before giving any dose, count apical pulse for 1 minute. For apical pulse less than 60 or greater than 100, hold the dose and notify the prescriber. Now, what if I've got an apical pulse of 61? Can I give it? Yes, I can. What if I got an apical pulse of 99? Can I give it? Yes, I can. A lot of times there's a reason why the doctor wants us to give it while we're here at the hospital, because it's a safe environment. So as long as it's hitting those parameters, you can go ahead and give it. Hold the dose to notify the provider if the patient is experiencing anorexia, vomiting, that blurred vision, seeing yellow or green halos around the objects. Avoid giving digoxin with high fiber foods. Fiber binds with the digitals. So you would avoid giving them things like bran muffins. You would avoid giving them anything that is high fiber. You want to always check your dose carefully, and patients should immediately report weight gain of 2 pounds or more than one day, or 5 pounds or more in a week. Your Milorone and Nesotride both use infusion pumps, and you want to monitor your inputs and outputs. And like always, just monitor your increased urine output, decreased edema, shortness of breath, resolution of your dyspnea, improved peripheral pulses, skin temperature, and just the general adverse effects. All right, thank you all.